My name is Kathleen Stengel, and I have the pleasure of moderating this panel of experts this evening. Just a few housekeeping items. I will go ahead and introduce the panelists and get us kind of started on the discussion. I also will be moderating questions in the chat. We will be able to, at the end, take you off mute and ask, kind of random questions if we need to, but please do, in fact, wait until I call your name, but notify me in the chat that you have a verbal question you'd like to ask at the end. So without further ado, please do keep yourself on mute until I do call your name. But Dr. Alberts, Rachel Swartz, Erin O'Brien, and Dr. Chadahumbe will be remaining off mute so that we can kind of create a panel-like discussion. So to briefly set the stage, this is about a diagnosis of autism specifically. We provide services through the full continuum of care for many individuals, but this particular presentation is about how the diagnosis of autism can impact treatment overall, but about how we can talk about synergies in autism care across the line from behavioral all the way through educational. It is very overwhelming sometimes for families when they obtain an initial diagnosis and hear a lot of acronyms throughout the recommendation for treatment from medical, behavioral, and educational professionals. So we felt like we got a good panel today to really hone in on some questions that a lot of our families have. And I'm happy to welcome this panel of experts. Dr. Chadahumbe, hello, good afternoon. If you scan the green bar here, you can actually get Dr. Chadahumbe's full bio, but she is our Division Head of Neurology and Developmental Pediatrics and Neuroabilities. And she joins us today to help clarify questions from the diagnostic aspects all the way through treatment. Thank you, Dr. Chadahumbe, for dedicating some time. Dr. Alberts is also with us today. He is a licensed neuropsychologist with many years experience. I won't out him with how many years experience, but he has clinical psych experience, forensic psychology, and neuropsychology experience for over 25 years. He's been our director of neuropsychology close to 15 years, I believe, and he has a wide range of expertise across many different neurological disorders, including developmental disabilities and autism. Thank you, Dr. Alberts, for joining us this evening as well. Erin O'Brien is our Board Certified Behavior Analyst and our Regional Director of ABA in the state of New Jersey. Erin has a lot of experience with early diagnostics as well as treatment, with a specific emphasis on involving caregivers, which I think is very, very important. Thank you, Erin, for joining us tonight as well. And finally, Rachel Swartz, who is a BCBA as well as a couples and family therapist. Forgive me if I didn't get that correct. Rachel has been in the field for a really long time and has noticed that there's definitely a lot of synergies between what the child needs as well as what the family needs. And she's offered to kind of combine those two areas of her own expertise to join us this evening. Thank you, Rachel, and welcome. So to get us started here, I'll ask the first question, thinking out about from diagnosis all the way through treatment. Dr. Chadahumbe, can you kind of give us an example of, or a conceptualization, so to speak, of some of the cases that you get in when somebody's worried about individuals or worried about the diagnosis of autism?
Thank you so much, Kathleen, for that introduction, and welcome to everybody who is here to talk about this. And yes, I think as a neurologist, I am perhaps the first physician or first provider that the family has come to, and they may suspect, or somebody in their environment or schooling has suspected them to have a diagnosis, and really want to kind of walk you through how we get from the concern all the way to the diagnosis. So we really try to take a holistic approach. And as I'm thinking in the back of my head about some of the known diagnostic criteria for the diagnosis, I'm really walking through the medical history very slowly. So understanding what the developmental milestones of the child are, understanding what some of the other medical comorbidities. Sometimes these children have had a history of complex heart disease. Perhaps they've had other medical problems that are really relevant to the story. I then try to understand a little bit about the family history. So an example is if there's a strong family history of hearing impairment, perhaps the child's speech impediment has to do more with a hearing problem. So it's really important to try to get a good context of the family history. And next, I really like to focus on observation. So this is where we take out all the toys. I like to get on the floor to play and see how this child interacts with me or with the parent or the other guardian who may be in the room. As part of observation, I love if there's other observers who can provide input. So perhaps if there's a teacher that's written a note or another family member, a church member that's written a note, that's really helpful for us to be able to understand how the child performs in different environments. I always love it when a family says, you know, child acts this way at dad's house, doesn't act this way at mom's house. I'm like, okay, child can't be autistic in just one house. So I really like to understand in different environments, how does this child interact? And then as I'm thinking about sort of the differential diagnosis of what else could be going on, right? Because there's other things that look like it that aren't autism. And so I really try to understand, well, is the child blurting out that, doctor, you're fat, is that really an autism problem, or is it an ADHD impulse problem? I really try to understand the intellectual capabilities that the child may have, and really trying to understand the onset of the symptoms. If the symptoms started last week, it's unlikely to be a diagnosis of autism. And so really getting all of that information, synthesizing it together, and certainly calling some of my colleagues to allow me to have a deeper look into it. And Dr. Alberts can speak more about this in a minute. But I really have gone through some screening and tried to understand, yes, I really have these concerns. Am I definite in my concerns? Am I probable in my concerns? And that really allows us to move forward into what we do next. Then I may consider some diagnostic other tests, so not just tests for confirming the diagnosis or refuting the diagnosis, but other medical tests that could confound it, such as the hearing test, for example. I think that's an important one that we need to think about when children have speech delay particularly. And there's some other tests that we talk about, and I can go into those in a little bit more detail as we go on. But I really love to collaborate with my psychologists, and really want to call on Dr. Alberts to speak to me about what he gets to do to try to help me when I find a child I'm concerned about autism.
Perfect segue, Dr. Alberts.
Thank you, Dr. Tadahumbe. Thank you, Kathleen, for the introduction. Dr. Tadahumbe, you make a good point. You know, kids with autism are typically obviously quite complex. Many are quite complex. But it doesn't require a psychological evaluation or a neuropsychological evaluation necessarily to result in or sort of render a diagnosis of autism. Physicians can do it. They do it all the time. Psychiatrists, developmental pediatricians, neurologists like yourself, and so on. So a lot of the cases that we get referred to for evaluation are oftentimes those kids that are maybe on the fence, where there might be a question of, you know, is this a, you know, kind of a pronounced case of ADHD with a lot of impulsivity and behavioral dysregulation, or with social interpersonal complications, or is it autism per se? So testing and evaluation by my department, my team, or the other psychologists out there is not necessary, but it oftentimes is an important part of the process. So there are a couple of different routes to kind of the psychological, the neuropsychological evaluation of kids or kids suspected of having autism. There's even an evaluation kind of protocol called a biopsychosocial evaluation, which is more recognized in Pennsylvania than it is in New Jersey. But again, a couple of things I want folks to think about in terms of evaluations. So a neuropsychological evaluation can be a comprehensive assessment, or it could be a more focused or targeted diagnostic assessment. What both of those approaches have in common, for the most part, is that whatever approach you take, be it psychological, comprehensive, targeted, et cetera, there needs to be a protocol sort of in place that allows the clinician, that allows the evaluator to establish whether or not the diagnostic criteria for autism are met or not met. So part of that process really entails a developmental history, and Dr. Tadahumbe sort of alluded to that as well. A symptom interview as well, fairly focused on the kind of targeted behaviors that we see in kids with autism. There are a couple of standardized measures out there. The Autism Diagnostic Interview, the ADI, is one that a lot of folks would recognize. There are others as well. So in addition to the interview and that history, a targeted or a comprehensive approach would as well entail administration or completion of inventories, rating scales, things of that nature. Some of those inventories should be autism specific and symptom based, but as well, it's important that we cover anxiety symptoms, depressive symptoms, ADHD symptoms, adaptive skills, and the like. We may talk later, but there is a significant what we call comorbidity or co-occurrence of anxiety, depression, mood problems, medical issues as well in kids with autism. So we can't just focus our assessment explicitly on the autism presentation, but we need to kind of consider other differential diagnostic problems as well. So interview, rating scales, questionnaires, there needs to be as well a direct observation element to whatever assessment, be it comprehensive or focused. And that can occur during the interview with the parent or the caregivers, or it could be a kind of a secondary component as part of the evaluation. And there are measures called the ADOS that you might be familiar with, the Autism Diagnostic Observation Schedule. So that's a kind of a semi-structured assessment protocol that really kind of creates social encounters in which the evaluator can observe or identify behaviors that would be more consistent with autism than not. And then when we think about comprehensive evaluations, again, not necessary for a specific diagnosis of autism, but it can help round out the picture. So a comprehensive assessment, certainly from my perspective, which is a neuropsychological perspective, might include IQ, cognitive testing, would likely involve memory assessment, language evaluation, measures of executive functioning, depending on the child's age, academic skills or pre-academic skills, and so on. If a comprehensive evaluation is not available to you, or if you kind of are more sort of inclined to go with a more targeted kind of focused diagnostic evaluation, a lot of times the child study team or the early intervention services, depending on the child's age, can administer some of these measures and tests and tasks to, again, help sort of round out the clinical picture of that child that's presenting with a question of autism. And sometimes, to get a child eligible for treatment, some insurance carriers may mandate specific measures and sometimes specific healthcare providers to render that diagnosis. So you need to kind of take into consideration what the goal of the evaluation is, again, targeted and focused on a diagnosis, or again, something more comprehensive, and what limitations may be kind of imposed by the healthcare insurer that you might be working with. So a long-winded answer, but a couple of routes we can take to kind of get to that ultimate diagnostic goal.
Very, very helpful. So, I mean, it sounds like there's a full continuum from the medical aspect that we have to rule out, as well as targeting almost a needs assessment, whether it be the focused or the clinical. And then that kind of sets the occasion for the next level of treatment, which I think most individuals would be referred, and correct me if I'm wrong, Dr. Alberts, over to at least initially to the ABA team. Is that accurate?
Yeah, that's the route that we take, obviously, in that, the psychology side of the equation, the medical side of the equation, we're certainly quite limited in terms of what we can deliver by way of interventions. So we put the burden typically of trying to cultivate skills and promote language and improve social functioning and the like to our behavioral colleagues. So why don't we hear from them?
So, and Erin, typically you get the children when they're at that end point where somebody says, hey, we've got a diagnosis of autism. They may also still be going through some of these other diagnostic or assessments with the family. But when you take it from there, how do you assess?
Yeah, so once we have that diagnosis, the child is matched to the BCBA, and then we complete an initial behavior assessment. And a lot of times at this point, and I'm also listening to all the assessments, parents are like, another assessment? What do you mean? But this one really helps us focus in on the specific needs and challenges and start to add to improve those things. So the first part of the initial behavior assessment is what's called a functional assessment interview. So the BCBA We'll conduct an interview with the parents. During this interview, they'll get information about the child's strengths, maybe some challenges that they're experiencing at home, any areas of need, and also really speak to the parents about what their goals are, what they want to accomplish through ABA therapy. After the initial interview is completed, we'll do an in-person portion. So at that point, the BCBA will get to work one-on-one with the child, just gain a greater understanding of what their skill level is, where those needs are. And then following those 2 assessments, the BCBA will write their treatment plan. And in that treatment plan will include the number of hours that are being recommended based on what the needs are of the child, individualized goals. So the goals will be very specific to that child's needs. It'll also include detailed teaching procedures of how we plan to teach those skills. And then also part of our treatment plans are caregiver goals. So we'll have goals specifically for the caregiver. Ultimately, we want to make sure that all these skills that we're working on during ABA sessions are carried over across all environments. I tell people all the time, if they can't take that skill out of the session and use it outside of the session, we didn't do our job. So ultimately, that's really a big part of what we do. The other part we'll look at is where those services will take place. So we have to take into account other therapies the child's receiving, their school schedule, all of that, and really look at what works best for the family in addition to what will be best for the child. And we work together to figure that out. That can be challenging. Kids are busy. They have a lot going on, and we want to make sure they can still be kids as well. So following finishing the treatment plan, we'll review with the parent, make sure we're all on the same page, and then we'll submit that to insurance. Then at that point, we match with a BHT. So the way it works is that a behavioral health technician will work with the child directly and implement the direct hours, and they'll be supervised by a BCBA for at least 20% of the time, and the BCBA will train the therapist, and then we'll also monitor the data, make sure progress is being made, make any changes to the treatment plan as needed as time goes on. And then every 6 months, we do reassess to make sure that progress is being made. We'll update any of our recommendations, update any treatment goals. So we're always looking at the data, making changes as needed, and then we'll make those changes based on the progress that's being made. But in addition, over that treatment period, so over that 6-month treatment period, we're collaborating with other team members. Our data can be used for medical appointments. They can see how medication's impacting things. We're making sure we're collaborating with school and other therapies, just to make sure everybody's on the same page and that we're all working towards the goals of the child and the family.
But as we talked from diagnostics through precise comprehensive assessments and then a behavior assessment, I immediately think, oh, as a parent, that feels like a lot. Rachel, from your perspective, how do we as, a community support our families? Because this feels like a lot.
Yeah, it absolutely feels like a lot. It is a lot. I've been in this role as a therapist, as a clinician, but also as a family member, as a friend. So I've definitely throughout my lifetime in this field have seen it from all different angles. And that's part of the reason that I pivoted, from the ABA, which I still am a behaviorist, that's still my home. But I've kind of translated some of that into like that family dynamic. So I'm hearing too, just like a lot of assessments, a lot of kind of like diagnostics. And then we do that also. Hopefully by the time, I've joined the team, I can actually use some of the assessments that have already been done. So we don't necessarily have to redo all of them, but, then we add kind of like a bigger picture, kind of check-in of just, something like, where is your family on the life cycle? Like, are you a parent with small kids? Is this like a teenager getting an initial diagnosis? Because that happens too sometimes. And that's really going to change things in terms of what that family needs, what that individual needs. And so we have an assessment we use often that's more like a global kind of big picture. What are the family's strengths? What are the relationships like in the family? What are some health concerns? Anxiety and depression among caregivers is extremely high. There's also, I think, I was thinking about it in preparation for this talk. I think a majority of my caseload, I work with a sibling, at least one sibling, on an individual basis, on like a semi-regular, like weekly, bi-weekly, monthly, something. But so just being able to kind of look at how is this diagnosis impacting the entire family, And in the family therapy world, we also look at time as a resource and how is that being kind of used in the family, or energy. Energy is a resource. How is that being distributed within the family? It's not always going to be perfectly balanced, but just for everybody in the family to be able to notice what they need, to ask what they need, to accept help. Those are kind of really important parts of what I'm looking for in the beginning. I'm looking for a lot of strengths, resilience. Have there been times in a family that things have been difficult and you've worked through it? How did that work? Is there anything that we can take from that time and apply it here? Who is in your support system? Like who's the friend that you can say, like, I've had a really rough week. Please send me the pictures of your cat doing ridiculous things, or like, do you have the family member that you can say, like, I just need to call you and cry right now, and I don't want any advice. I just need to be with someone when I cry. Like, who are those people for you? And everyone kind of needs those people. And I'm really just looking at caregivers as individuals, so Erin was talking about having caregiver goals, and that piece is extremely important. That's definitely part of my pivot. Was I was doing a lot of parent training, and I'm like, wait, but the parents, like, did they sleep well last night? What's their vitamin D level? Because there's a lot of things that happen for parents as individuals too. And just having sessions about, like, how is your sleep? When is the last time you did something fun? Just trying to kind of balance all of that. I would say the family therapy role is about taking all of the components that you've heard already, and how do we make that actually work in a family system? So I hope that is a helpful introduction.
I think it continues the complexity of what it is that our patients and families need. I think it's not autism, it's autisms with an S. And then the impact of autisms in a family unit, it's disruptive and it's scary. And I think we've elaborated that full continuum of care. But in thinking about progress moving forward, Dr. Chadhambe, I'm going to ask you, what do you think about in terms of progress for some of the kids that we work with, and how we set them up for success? I mean, and given all of this, that there's so much support that's actually required.
Yes, I think everyone has spoken to how it really does take a whole team of individuals, a family team. There's going to be the clinical team, the behavioral team. And the more that there's collaboration between those teams, the more successful that child actually does. And so I really love when I can get feedback from all of the team members in terms of, I've only spent perhaps an hour and a half with the child, but you've spent many more hours. And your feedback to say, listen, Johnny only has trouble when one of these circumstances are in place, or, when he's in this environment. Well, that allows me to know kind of what I need to do as I tailor my management, my diagnostic plan, so that it is just for the child. We do not like the shotgun approach where I run every test on every child. I really want to be able to make it very directed to the child, and then make the treatment very individualized to that child. So really allowing and hearing from all of the team members allows us to do it in a more accurate way. And I really love what you said, Rachel, because I think as a clinician, I'm quick to forget that this family has just been hit with a lot of information. And there's nothing that needs to be done right now. So even if I'm asking for certain tests, really reminding myself to remind the family that we're not in a rush, right? This is going to be a long haul marathon, and we'll just take it step by step by step, and really allowing them to digest, to process each step of the way, and not really put them in a place where they feel overwhelmed. So thank you for reminding me about that.
And there was a question that came into the chat about collaborative teams, and along the lines of being overwhelmed. The question is about, is there ever too many therapist cooks in the kitchen? And Rachel, I think I know your answer on this one, but to follow up with that, how do you avoid that? And on a collaborative team like this, like, who functions as the case manager? And I think we look at it a little bit differently, but I'll let Rachel, if you want to take part of this, and then we can have others chime in.
Yeah, absolutely. I guess my answer to most things is it depends. But one of the things that we all do very early on in this assessment process and the treatment process is we get releases that we can talk to each other. And I think I find that to be extremely helpful so that the parent isn't necessarily the one coordinating everything, but the BCBA or I or any of the doctors, the physicians that you're working with, that like they can send me an email and be like, are you free 15 minutes, you know, anytime in the next 2 weeks or whatever to touch base. And that doesn't necessarily have to be the Neurobilities team either. That's everyone. It's a little bit easier when you have those relationships within Neurobilities, but it's really important for all of us that we're taking the initiative for that part. And there are some families that, you know, they don't want a lot of inner, you know, collaborative, whatever, for whatever reason. And we respect that also. But it's just having those releases, having that assessment period. I think Erin and our assessment periods typically are about 30 days max. And the insurance and funders generally give us sometimes enough time that we can do some coordination in that, just right from the beginning of introducing ourselves and our role and just asking how we can work together. But as much as possible, taking that initiative so the parent doesn't have to be the one in charge of it is how I would look at it. But yeah, Erin might have some other ideas of what she's seen in the field too. So
yeah, Erin, I think you get to see the kids more often than the physician does, or the psychologist, or even the counselors.
Yes,
you function as the clinical care coordinator.
Yes, we have the most contact hours with the child. So typically we try to take the lead as far as making sure all that collaboration happens, initiating that. We find out if there are outside providers that aren't with Neurobilities, we'll reach out to the parents like, can you give us the contact information? We're happy to reach out, so that it kind of takes it off of the parents' plate as well, as Rachel had mentioned. But it just seems to make a lot of sense for the ABA team to take the lead with that, since they have the most contact hours with the child and the family.
And typically, because the school, we haven't spoken about the school, we tend to focus on the medical determination and the clinical determination. But Erin, you guys also interact with the schools as well, correct?
Yes, we're available to attend IEP meetings, which we're all busy with that right around this time of year. And then just ongoing collaboration with the teachers. I've met with teachers without the parents even being present, obviously with parent permission, but just so that, you know, it also takes that off the parents' plate. They don't have to be available for that, but they can feel confident that, you know, the ABA team and the educational team are working together, that they're all working to be on the same page. We collaborate with outside speech therapists, occupational therapists, and then as well as like other medical providers, just to make sure, you know, that everyone's working together. But as much as possible, we try and take that initiative to help the parents with that.
Awesome. And there's actually a follow-up. And thank you, Mr. Jones. I hope we answered your question, at least to the best of our ability. But Amanda Gray has asked, have either of the BCBAs cross-trained as case managers? And I'm going to giggle because, you know, I think part of our training is managing our case, but not necessarily at the kind of the social worker aspect of making sure that the I's are dotted and T's are crossed across different funders. I think that's one area that becomes overwhelming that isn't clinical. Is that accurate, Erin?
Yes, it is. I mean, personally, I, in a former life, was a LDTC in New Jersey. So I was a case manager on the child study team. So I had, you know, it was an overwhelming job. I think I had 60 some kids on my caseload, but you're collaborating with the teachers, all of related services providers, the parents, any outside providers. So I have had experience with that. And I think it's helped me be able to take that into this role and use that skill set, and also kind of transfer that to other BCBAs that I'm working with to help them be able to manage that as well.
I don't think we intended to cross-train people, but I think it's resulted in us having to cross-train people. Hopefully, Amanda, that answered your question as well. So this does sound like it's complex. So there's a lot of different facets of this, dealing with just kind of the full comprehensive. As we move forward, some of the questions that we got prior to this were regarding parent involvement. And I'm sorry I'm going to pick on you again, Erin, but Greg, I'd love for you to chime in. Participating in the child's treatment and in therapy. Erin, how important is that, number one? And then I'd love for Dr. Alberts to kind of chime in and say, from your perspective, how important is it as well?
It's extremely important. And as I mentioned before, I kind of touched on, if we want to make sure that all those skills that we're teaching during ABA sessions are being used outside of ABA sessions. So a lot of that involves making sure the parents know how to help with those skills in the home setting, outside of ABA sessions, and also teaching them how to manage challenging behavior, what the functions of behavior are, how to recognize those functions so that they know how to respond, so they're not inadvertently reinforcing these behaviors. So a lot of that goes into that. But at the same time, and Rachel can kind of speak to this too, we have to meet the parents where they are. So, we could look at a situation and see a million things that need to be fixed or that need to be changed, but we're going to start with that smallest little thing so that the parents see that progress, and then we can kind of build upon that. So we don't want to go in and overwhelm the parents either. So each case is very individualized. Some parents are in there, they're ready, they want to go, teach me everything. Other parents are completely overwhelmed. We're going to start with that tiny little baby step to help them learn those skills so that they can help those skills transfer outside of sessions. But that piece is very important. But again, like if it takes a long time, it takes a long time, and we have to meet the family where they are.
Dr. Alberts, from your perspective and years experience, how do you see this?
Let me sort of excuse me, add to what Erin had to say, and I'll speak really in terms of what I see a parent's role in terms of participation in say psychological counseling or a therapy that would be more sort of typically more of a sort of one-on-one individual-based approach to treatment. And I think we need to think about this as well in the context of Christopher's question a few moments ago about kind of throwing the kitchen sink at these kids. More is not necessarily better, and there's a time and place for all of these treatments. But from the standpoint of psychological counseling, therapy, and so on, I always encourage parents to, if they can, depending on the child's age and what the therapist's level of comfort is in sort of engaging with the parent in this process. Certainly, I think it's important that they participate in the initial session, the intake session, so that they can really collaborate with their child and the therapist in terms of setting up, appropriate treatment targets and therapeutic goals and the like. There are some therapists that really invite ongoing participation and engagement by the caretaker. There are others that from what I've heard from parents, that really want that kind of the privacy and the sort of that therapy sanctuary to kind of maintain in place. And I'm more of a proponent to have parents advocate for as much participation in therapy as possible. So there's initial kind of goal setting. How kids behave in a therapy encounter is obviously much different than how they behave at home. So, it really speaks, I think, to the benefits of having parents provide input in terms of what's, actually and literally happening, kind of in the home environment or in the school context, things of that nature. So, it's a matter of, again, engaging with the therapist, trying to talk your way into participating in as much of the treatment as is appropriate. I've had parents who have asked to have a kind of a post-therapy session debriefing of 5 minutes. Of 3 minutes, whatever the case might be. Email communication is obviously another mechanism. I've encouraged parents, and I know parents have advocated actually to sit in on a session so that they can see what's going on in the therapy encounter. Erin kind of spoke to the need to generalize what transpires in an ABA session to, real world context and home environments in the school setting and so on. And I think, one of the primary missions of a therapy encounter is for that child or that patient, that client, that learner to translate what they've learned in a session to, more important environments outside of that therapy environment. So in order to kind of facilitate that generalization, that application of skills that, hopefully are being taught in the therapy session, that's going to require, in most cases, a lot of parental support, caregiver support. So there's a very good case to be made for active parent caregiver participation in treatment. It's a balance, and a negotiation oftentimes with the provider to see what that's going to look like. But I think the benefits of doing so far outweigh any intrusions on privacy or any interference with, the sanctity of the therapy relationship or the kind of the privacy of those encounters. I think there's the extent that it can be really a collaboration with the parents or caregivers is going to make for a better outcome.
I think that's very well said. There was one question in the chat about, do you work with siblings? And if so, how do you involve them? And I know that that's, one of Dr. Chadahumbe's, that's one of your major areas of emphasis, making sure. But I think Rachel and Erin, I'm going to let either one of you take that one first, because I know there's sometimes parent or sibling goals that we implement on both, from a therapeutic intervention as well as ABA.
Yes, we definitely include siblings. I wouldn't say the sibling is receiving the direct treatment, but we will absolutely incorporate them into sessions. We'll work on interactions with siblings, collaborative play with siblings, just all of those types of things. It's really important. It also helps with that generalization piece as well. So if they're able to really work on those things during an ABA session, and then we leave and they carried over after that. So siblings can be definitely a big part of our sessions.
And Rachel, I think you look at it a little differently in terms of how you support the family unit with the siblings. Is that accurate? So Erin is assuring that everybody in the child's family understands how to implement treatment, so to speak, treatment in air quotes. How do we interact? How do we communicate? But from your perspective, you look at it differently, right?
Yeah, this is actually a huge part of my shift to family therapy. I will never forget, I had some clients that I was working with in a clinic-based setting, and then I transitioned to working them in the home. And I got to see the dynamic with the siblings happening. And I just had this moment of like, there's something happening here, and ABA is not giving me a language or a template to describe or to sort or organize or understand any of it. And that was really when I was like, I need to go back to school. Like I can't keep pretending like I don't see things. So Erin, I 100% agree. And I think like mobile therapy can also support with that, with a lot of like how to have safe communication between siblings. That is a huge part of what a mobile therapist would do. But there's also this other piece of, assuming that a sibling is neurotypical, their development is really important to keep an eye on also. And what I've seen over the years is like, there's a very, I don't know, typical is not the right word because it doesn't always occur, but it's a common pattern that a neurotypical sibling can take on this role, like responsibility for their sibling that has any kind of neurodiversity that needs, extra care. And so I've really been keeping an eye on that with the siblings I've been working with, was saying, you know what, you don't have to actually participate in this session. Or, if you just want one-on-one time with me, we can build that into the session too. And just sort of at least giving them that choice, giving them that option. And just really keeping an eye on like those boundaries, to use a very therapy word. And sometimes it can also go the complete opposite direction where there's a sibling that's like, I want nothing to do with that sibling. I don't want to play. I don't want to participate. And then kind of looking at, okay, what's going on with this sibling and what needs, might this sibling have that aren't being addressed, and how can we work as a family to get those needs met too. So, I 100%, I'm like, yes, siblings involvement, but also like siblings as individuals too. And that's where it kind of changes from the scope with ABA.
Yeah, and as a parent, I know it's difficult to manage that kind of holistically, but from a medical perspective, if I could pull the thread on sibling a little bit, Dr. Chadahumbe, oftentimes families have a diagnosis, and whether the diagnosis is the older individual or the younger individual, there's still an oh my goodness concern. From a medical perspective, that makes a big difference because sometimes there are genetic things that transition between. Could you opine for us and pull that thread a little?
I think absolutely. I think it's often interesting as you're meeting families and you're making a diagnosis in a family where there's multiple siblings, because the parent starts to have almost an immediate panic that, oh my goodness, have I missed something in the older siblings who came in with this, that, and the other. And so it really is an important piece to be able to, like you say, Rachel, to be able to look at the family as a whole. And then I always get well, I think maybe I have it too, because I have or had a lot of the similar types of symptoms. So really trying to bring the family along, helping them to understand what is normal, what is considered to be neurodivergent, helping them understand the implications. So I get to talk to them about family history, about genetics, and siblings that may look unaffected, what is the impact that it may have on them. So there's really multiple layers to the family dynamic. But I really have to say that in the clinic, I am very aware on how this diagnosis may impact couples, right? Families that are really trying to stay together as a unit. And oftentimes couples are no longer couples after a few years. And what can we do as clinicians, as providers, to help them stay together, help them understand that we are supportive and supporting them through this process. And it can be difficult to start off with, but things will get better. And what can we do? What can we say? What can we do to try to help support the process? So I think is really important on all fronts.
Yeah, thank you so much. And Dr. Albert, you've been in this field for a really long time across many different clinical, neuropsychological. You've met many families. I mean, you've seen the impact that it could have, detrimental to a marriage as well as to the siblings. Do you care to opine?
Yeah, I'd actually like to focus on what oftentimes can be kind of good news with the diagnosis. You know, I've seen parents, as we all have, for whom we've delivered the autism diagnosis, and it has been, you know, it's been traumatic. It's been, you know, challenging. It's been frustrating. And we've had the opposite effect as well, where parents long suspected that, you know, there was a social behavioral concern with their child. The pediatrician may have deferred, you know, a diagnosis or an opinion, or, you know, adopted kind of the watch and wait sort of mentality and so on. So we've diagnosed kids with autism. Parents, and I think with the amount of information that is out there these days in terms of autism prevalence and autism services and so on, it seems to me to be less stigmatizing than it was, say, 10 or 15 years ago. So with the diagnosis, you know, the good news for many parents is that most health insurance covers autism treatment with the right documentation and the like. We know that there are effective treatments out there, ABA obviously being one of them, other psychological therapies, medication management, so on and so forth, can make a big and significant difference in the lives of these kids. So yeah, an autism diagnosis is challenging, but sometimes without it, you know, parents are sort of, you know, kind of drifting in the wind and not sure about what next steps they should take. So, you know, there are lots of advocacy agencies out there. I think the general public is certainly more in tune with what autism is. There's I think more tolerance and more acceptance. A lot, you know, we have a long way to go as well, but the diagnosis itself, you know, is going to influence families differently.
Thank you, Dr. Roberts. It's a great point. Oftentimes there's a relief that at least there's something, oh, thank goodness, now we know, and that actually strengthens the core. So thank you for always being positive and bringing it back. There was a question from Carolyn about any suggestions for clients or siblings. Parent recently diagnosed with ASD and has an overwhelming feeling of guilt. I know that has happened in many, many different cases. Dr. Chowdhury, you've said like, oh my gosh, I have always been like that. And then maybe, you know, a diagnosis ends up resulting later on in life. And then the family feels very guilty, or the parent feels very guilty. Have you had any experience with that?
Yes, I have had experience with that. And I typically will say in those settings that that's often good news, right? That you are here today as a testament of having a similar diagnosis, and your outcome is such that you are able to bring your child and advocate. So this is our goal. This is our goal in helping your child, is getting them to be that parent one day to whoever else that they will have to take care of. So I think that it's often an area of optimism, never an area that I want anybody to feel guilty. I think as parents, we're often made to feel guilty about a lot of things, but nobody causes this to happen. No one does anything to intentionally cause a child to have a diagnosis such as this. And really allowing us to be able to make the diagnosis early allows us to support the child and hopefully have a better outcome than what even you and I would have had.
That's very helpful. We have two other ones that I'd like to address. One is I have parents often who've researched ABA, and there's a lot of, oh, goodness gracious, myths and negative experiences. And without having the BCBAs answer this one, I'm actually going to punt it over to Dr. Alberts, who is not a BCBA, so he's more unbiased, hopefully.
You always give me these hard questions. I was looking for softballs.
You know, years and years, that's what it gets you.
Yeah.
It gets you years and years and hard questions.
You know, I think our approach to that question, when it comes out as a you know, directly from a family member or a patient that we have referred for ABA services, I think it's important to kind of start out with what their understanding and or expectations are for ABA therapy. And I think, you know, it's a matter of, you know, kind of gauging where they're getting their information, what resources they've tapped into. You know, there's a lot of misinformation, believe it or not, on the internet, or so I've been told. So it's important really to kind of find out, you know, where this bias might be coming from. And I think it allows for an opportunity at that point, I think, to, you know, dispel some of these myths, and or, you know, kind of challenge them perhaps a little bit more directly. But the other thing that I oftentimes will direct parents to, there are resources on the internet that really focus on helping parents sort of understand the science behind ABA, for example. There's a nonprofit organization called ASAT, Autism Association for Science in Autism Treatment, ASAT, which will, you know, provide a list of resources and citations and references that provide empirical support for ABA. And I think there's also material on there that will, you know, challenge this belief or this bias that ABA therapy creates little robots, or it's all about stimulus response, or it's all about repetitive drills, things of that nature. And sometimes ABA is that by certain providers, but I think, you know, it also sort of, you know, pushes the parent, the family member, the caregiver to investigate, you know, the qualifications of the ABA provider, you know, meet with them, talk with them about these biases, find out what transpires in the therapy sessions. And equally important, and this gets back to, you know, parent engagement and participation in therapy, is you know, collaborating on treatment goals. You know, what's important for you as a parent in terms of your child's development, their next steps. You know, oftentimes it's language, it's socialization. Some parents want to emphasize more so than others academic skills and so on. So yeah, so I think, you know, there are biases out there. There's sort of anti-ABA groups, but, you know, when you kind of get down to it and look at the science and the validation studies, you know, it's the model, the method that works best in most cases. And it's certainly what I advocate for.
And I would just chime in. Definitely, I am a board certified behavior analyst, so this is not coming in unbiased. Having said that, I've been in the field for close to 30 years, and ABA is really the science of learning. And what we learn has to be collaborative with the families. I think that's really the key here. It's not so much ABA is a method. ABA is infused into education. Really good teachers are the best behavior analysts I've ever seen, because they understand the art of learning all the way through. And I think the key really is that, you know, the assessments across the board, and to hold ourselves accountable to getting consent, number one, and then also making sure that we're working with the individual, their family, and what they want, and to select the right skills that we can build programs around. So I think there's a lot of information out there that's either outdated or, to your point, Dr. Alberts, it's not the best out there. I think the key is to find a high quality behavior analyst and a program that will work with the entire individual. So it's a question we always get, and I bring it back to, it's the science of learning. We can teach any skill. The skill's got to be selected by the family. And I think that's where, you know, coming through the medical, from the psychological, from the behavioral, as well as making sure to look at the cultural aspects of the family. I think that's where I usually talk to parents and say, it's not a modality, it's not a treatment stamp. And instead is a methodology by working towards positive, proactive. So I'm sorry, this is one that, sorry, Rachel and Aaron, I'm going to move on. There was a question, and Dr. Chadahombe, if you don't mind, there was a question about the ECHO model, which I think we all are very much a big fan of, and almost like an internal replication happens at our organization. Are you familiar with the ECHO and the telehealth model? And do you mind just opining on it?
Sure. So at least and maybe there's several, but the one that I'm most familiar with is one that is really allowed for autism education to reach more communities, medical communities, because as you know, getting a diagnosis or having a child formally get diagnosed, there's often a wait time, a year, sometimes 2 years. And depending on that community, there may not be enough specialists to be able to do it. So this has allowed for a platform to be able to communicate as clinicians, where you have direct contact with experts who are very well versed in the diagnostic and can really allow for a clinician to learn how to apply some of the tools, such as the CARS tool as an example. It also allows for the discussion of difficult clinical cases to get advice about some of the clinical cases that may be more challenging. But my experience with it has been on a clinician end. And so that's really what I've seen. And I think it's really been a great tool to be able to connect, especially pediatricians who have an interest in learning, who have an interest in providing more diagnosis and really helping to lessen the burden and delay for diagnosis.
And I do think that in at least our area, there are a lot of programs that have a while you wait on a wait list. And it's based on some of the ECHO models. So if there's any questions about that, we can follow up with some resources, at least in the Philadelphia Metro. I think we have time for possibly 2 more questions. Oh, Emily, okay. Well, we will follow up with you directly. It's a beautiful model. But the next question I'd love to, actually, Rachel, if you don't mind, this gets back to fatigue and burnout. So thoughts on best practices for managing, this is the child's fatigue and burnout. Like sometimes our kids get 40 hours worth of intervention, and, you know, not many people who work for a salary work for all of those 40 hours, yet we're expecting our kids to. So how do you account for the burnout for the children kind of holistically?
Yeah, and Erin might be able to speak to this too, because the ABA model is typically the one that is using a lot of that space. At least in the model that I was trained under, we tried to have the ABA like integrated as much as possible across the day, across the different therapies. So, you know, if you were getting a 20-hour a week script, how much of that is actually co-treating with speech, with OT, you know, with a mobile therapist, going to school. I was really trained under like that 20 hours is kind of like all of it. It's not in addition to. So, and the other part too is like, and I think this might be part of the ABA assessment process. We're asking parents, like, when do they nap? When do they get tired? You know, how long do you think a session can be? Can we start at an hour and move up, you know? So I think we do try really hard to map that and to check in and to change it, to make adjustments as we go. But Erin might have more to add to that too.
Well, let me ask you, Erin, like, so in treatment that is a large volume, how much is intensive percentage-wise versus how much is play?
I think we always try and incorporate some of that naturalistic approach, that, you know, natural environment teaching, following the child's lead. So obviously everything's individualized, but we definitely want to keep as much of it as natural as possible, because that helps with generalization. It helps with children to be able, again, as we've been talking about, take that skill and use it outside of sessions. There are certain skills that obviously are better taught at a table, you know, in that kind of format, but overall, we want a chunk of that session to be as much natural environment as possible. And also on top of that, I think the important thing we want to highlight about ABA is, like, ABA is not a lifelong service. We are always working ourselves out of a job, where our intention is to get the child to a point where they're good to go and they don't need us anymore. And then that's when we consider our job done. So I think it's important to remember that, like, in collaboration with the family, if you feel like it's not working, if this is something that's not working for you anymore, like, that's something we can talk about as a team. and decide, maybe it's time that, they're ready to graduate from ABA. But I think that's always an ongoing discussion to have with the family.
Dr. Alberts, do you have any opinions on the fatigue? You see it with some of the patients.
Yeah.
Almost over therapy.
My quick thought about that is kind of gets back to looking at the goals and objectives of each provider. And that's where the case manager or the quarterback kind of comes into play. And sometimes the parent serves in that role. And looking for redundancy, seeing, what could be maybe assumed by the speech therapist as opposed to ABA or vice versa, and so on. Sometimes redundant goals are good from, different treatment provider perspectives and so on. Sometimes having the same goal addressed by two different providers could be conflicting and contradictory and so on. So I think it takes that sort of careful survey. And again, more is not always better, and the whole kitchen sink approach just isn't in a kid's best interest in most cases. But sometimes you need to really prioritize based on what is most pressing in the moment. And we've had parents, as you know, in the past who had the resources, they had the time, they had the energy, and they tried to do everything for their kid. ABA treatment, speech, occupational, PT, executive functioning coach, hippo, horse riding therapy on the weekends, down at Disney, riding with the dolphins, whatever. And, some kids can accommodate and tolerate that, other kids can't. But it's really, I think, a matter of sort of setting, priorities based on, presenting problems and what the current significant treatment targets are, and trying to, do so in a way that's, economical time-wise and provider-wise.
Yeah, I agree with every panelist on this one. You have to create the most efficiencies as possible. Time is our most valuable asset. And so what's the best use of our time across the board? And then from a burnout perspective, I've always said if ABA ain't fun, it ain't worth doing. So they shouldn't be getting burnout, at least from the development of the skills, because if they're developing their skills, they should be having fun and using them and contacting lots of reinforcement. So we have about 2 minutes left, and I don't have any further comments or questions in the chat. So anybody else who wants to ask a question, please feel free. We probably have time for one additional, but maybe to summarize things up, Dr. Chadahambe, do you mind giving us kind of the holistic view about what you look like in terms of what it looks like for outcomes for this population? I know that's a really hot topic, and I only gave you about a minute and a half to respond to it. So please feel free to fix it.
I would just say that outcomes are going to be improved by greater collaboration. Outcomes are going to be improved by greater individualization. And so what does that look like medically? We talk about, specifics to even if it's medications or supplements. So it's really trying to individualize that treatment as much as possible. And of course, we are available if you are looking for any one part or all of us. Thanks again, Kathleen.
And I want to take this time to just thank my panelists. I have the greatest job ever of getting together the smartest and most well-intended individuals with high values. So I fully appreciate you guys dedicating your evening to us and to answering any questions. So on that, I'm going to go ahead and close that out. Thank you to everybody who attended, and thank you for the amazing questions. This was awesome, and I hope everybody at least learned a little bit, and feel free to, we will be reaching out subsequent to this with the link for the video. So hopefully everybody has a great evening. Thank you to the panelists. I owe you one.
I know. See you, everybody.
Bye-bye.